Good morning, everyone. I'm privileged to introduce this workshop today and welcome you to our radar community. I would like, first of all, to thank Dr. Mario Iaquito, Radar Project Advisor at the European Innovation Council and SMEs Executive Agency, who could not join us today for health reasons and is providing guidance for the successful implementation of Radar Project. A special thank also to Jon Arizabalaga from Aguas, who is doing a really excellent job in supporting the coordination effort and without whom this event wouldn't have been possible in such a short time. I would like to thank the speakers for sharing their knowledge today. I would like just to say a few words about the relevance of antimicrobial resistance, because we are currently witnessing an increase in antimicrobial resistance that is yet another medium long-term effect of the COVID pandemic. And we are aware that in order to contrast it, we need to take action at multiple levels and in different settings. European projects have been generating a bulk of innovative results, methodologies, and approaches that we can use synergically to this purpose. And international networks provide an excellent environment to foster such exchanges. And I hope that today's webinar will be just the first one in this direction. So just a few practicalities. The chat will be closed, but there is a Q&A space open, and we will do our best to reply today if there is space and room, or by email if there is no time. Without no further delay, I'm pleased to leave the floor to John Farrell, the RSCN Director. John, the floor is yours.
Thank you very much, Madalena, and I'd like to join Madalena in welcoming everyone to this morning's webinar. We have a very exciting agenda, and I'm just going to spend just a minute just to introduce all of the speakers, and then we will start the first session. So we will, I'd like particularly to welcome Dr. Silvia Bertoglio from the World Health Organization, Samira Busetta from the Director General GROW's activities within the Commission, Jose Arroyo Nieto from looking at the whole concept of on the position of the patients and patient empowerment, and Professor Marie-Cécile Ploy, who's a professor at the Meuse CHU and is a coordinator of another European project. Also to Jon Arizabalaga, who will also be joining us to talk about the Radar project itself. And then after we have the session with the individual speakers, we will have a round table, which will be moderated by Rossana Alessandrello, and she will be joined by Ana Alvarez, Professor Gerno Marx, and Francesco Tesarolo to discuss the value-based and to discuss, AMR within the context and the good practices and learning we can get out from that. So without further ado, I would like to welcome Dr. Silvia Bertoglio, who's a doctor and the head of unit at the Control and Response Strategies unit within the World Health Organization AMR division. Dr. Silvia, I will hand the floor to you.
Super. Thank you so much, John, and thank you so much, Madalena, and the organizing committee for inviting me to contribute to this important webinar today. So as John mentioned, my name is Silvia Bertoglio, and I work at the World Health Organization, and I am leading a unit that is in charge of in the antimicrobial resistance division that is in charge of research and innovations and for policy development, as well as diagnostic and laboratory strengthening for AMR. So I'm going to share with you today, the preliminary result of a research that WHO has been coordinating over the last year or so, looking specifically at the intersection between antimicrobial resistance and the COVID-19 pandemic through the WHO Global Clinical Platform for COVID-19. And so I want to start by highlighting the importance of the intersection between the two pandemics. And people, an expert at the beginning of the COVID pandemic were wondering whether this would result inevitably to a decrease of antimicrobial resistance, because several interventions have been put in place as a result of COVID-19, including physical distancing, including hand hygiene, reduction of influenza rates that have been observed, a shift in the healthcare utilization, and then a reduction in terms of global travel. So these were all good arguments to support the hypothesis that antimicrobial resistance would actually decrease as a result of COVID-19. Now, but there were other arguments to support the hypothesis that actually antimicrobial resistance could increase as a result of increased antibiotic use, altered of screening of MDRO, multi-drug resistance organism, in many settings, in many facilities around the globe, as well as the the intervention, IPC related intervention that were compromised in many facilities around the world due to high burden of patients hospitalized with COVID-19. So a systematic review and meta-analysis that we have, WHO has been supporting and co-authoring, is looking at studies during the pre-COVID time and in cohort of patients during the COVID time. And we compare incidence of antimicrobial resistance in the two cohort of patients across 23 studies. And what we have been seeing indeed is that there is not an increase in the incidence of gram-positive and multi-drug resistance organism, but we did observe an increase in the incidence of gram-negative NDRO. And this increase was statistically significant and important, really, particularly in facilities where there was an absence of IPC enhanced interventions or stewardship interventions during the COVID time. So clearly, these results, shift kind of the argument towards the kind of the fact that AMR actually is increasing as a result of COVID. Now, another systematic review and meta-analysis looking at study level data, over 148 studies, identify, again, high prevalence of antibiotic resistance pathogens in patients hospitalized with COVID-19, but importantly identify that risk factor for resistance were ICU setting, comorbidities such as diabetes, antibiotic use, as well as presence of the facility in low middle income country setting. Now, clearly, antibiotic use play a role in the emergence of resistance and is the predictive factors. Now, despite WHO recommended since the very beginning of the pandemic not to use antibiotics for the management of COVID-19 patients, we know that they are commonly prescribed among those patients due to diagnostic uncertainty or for concern of possible bacteria co-infection. And this slide shows you the clinical management guidelines of WHO that has been updated since March 2020 and continue to recommend against the use of antibiotics in patients with mild illness and patients with moderate illness. And highlight the need to treat co-infection based on laboratory confirmed diagnosis or epidemiological or clinical criteria. A review of national guidelines on the clinical management of COVID-19 across 10 African countries have highlighted that indeed in some countries antibiotics are included in the national guidelines for the management of even mild COVID-19 patients. For example, in Liberia is recommending or has recommended antibiotic in mild, moderate patients with COVID-19 with a sore throat or coughing or diarrhea. In Ghana, antibiotics were or are recommended in COVID-19 confirmed case with even asymptomatic or mild or moderate symptoms. Another important finding is that the type of antibiotic that are recommended in those guidelines, they belongs to the watch category of the AWARE classification and the reserve category of the WHO AWARE classification. As you know, WHO recommended at least 60% of all antibiotic prescribed in the countries belongs actually to the access category of the aware classification, which is the category that is less prone to emergence of disease, of resistance. So to have a better understanding of the clinical phenotype, clinical care and therapeutics and risk factor associated with COVID-19 in different geographic regions of the world, in subpopulation and over time, WHO has launched in March 2020 a global initiative called the WHO Global Clinical Platform for COVID-19. And WHO has invited member states to share individual patient anonymized data, clinical data of people hospitalized with COVID-19 using a standardized case report form that you can see on the right-hand side of this slide. The standardized case report form allowed the collection of standardized data that can be compared and pulled together to have a better understanding of COVID-19 clinical characteristics around the world. And WHO is still continuing to engage with Ministry of Health, with individual facilities and research network, and encourage them to share data with WHO on hospitalized patients with COVID-19. So far, as of December 1st, 2022, the clinical platform has received over 1 million individual patient level data, mostly coming from the African region, 50%, followed by the European region, 38%, and followed by the Americas, 9%, and less from the AMR region, CRO region, and the WIPRO region. And the data are displayed on the WHO Global Clinical Platform webpage that you can see on this slide, and you can go to the web link and see what high-level data do we have. Now, we wanted to use this large data set to have a better understanding of the intersection between COVID-19 and AMR in people hospitalized with COVID-19. And specifically, we asked 3 questions. What are the patterns of antibiotic use across region, countries, subpopulation, and over time? Number 2, what is the prevalence of bacterial co-infection and infection caused by resistant organisms? And number 3, does empiric antibiotic therapy influence clinical outcome? Now, and about 450,000 patients with antibiotic information were included in this analysis, and you can see mostly are coming from the Euro region, mostly from the UK, Switzerland, and then to lesser extent, Italy and Spain, and then France, and 14% from the Afro region, the Americas, and then less from the AMR, WIPRO, and CRO region. So what these data tell us? They tell us that among all patients hospitalized with COVID-19 that are in the platform, as I said, over 450,000, 77% received at least 1 antibiotic during the hospital stay. Among patients with severe critical, 83% receive antibiotic. Among patients with mild or moderate illness at hospital admission, 74% receive antibiotics. No big difference in terms of age. Of course, older patients receive more antibiotic, 80% of them, but still patients with less than 18 years old still receive, 60% of them receive antibiotics. A lot of high frequency of antibiotic received in patients in the African region, almost 100%, 98%, 96%, apologies. But also in the other regions, so in the Eastern Mediterranean region, 80%, and the European region is about 67%, and is slightly less in the CRO, AMR, and WIPRO region. If we look at whether those high level of frequency of antibiotic use has changed over time from the beginning of the pandemic, we do see, for example, that in Afro region, there is not a kind of a movement towards a reduction of the use of antibiotics. And so, as you can see, about 87 or 89% of people still receive antibiotic, even in the first semester of 2022. And you don't see a big difference between those with mild disease, which is the light blue bar, and those with severe disease, those with the darker blue bar. You can see that, basically use of antibiotics is almost the same across the 2 groups. In the Euro region, we do see a decline in the use of antibiotics over time. But this decline is not very significant, I would say, but we do see in this region a difference between the mild to moderate patients, which is the light blue bar, and the severe patient. And of course, severe patients receive more antibiotic than the mild moderate, but still in this group, there is still a high proportion of those receiving antibiotics. And when patients receive antibiotics during the hospital stay, in 75% of the cases, they receive it during the first 24 hours, so purely empirical therapy. And in some countries, 100% of those receiving antibiotic actually receive it during the first 24 hours of hospitalization. And we do see that in most countries, there is no difference whether the patient is mild or the patient is severe in terms of antibiotic use. In some countries, for example, like in Ghana or Malawi or Nigeria, doesn't make a difference, the illness, severity of illness at hospital admission. While in other countries, of course, that is different, like in Jordan, for example. We also see that in the number of antibiotic of molecules, of agents provided at hospitalization is quite astonishing. In some countries, more patients receive 2 or more antibiotics compared to just 1 antibiotic, which is, of course, concerning. We also do see that in the over 80% of antibiotic prescribed are from the watch group, and which is the yellow dot here that you can see. In all countries, the watch category is mostly utilized. While we want to see actually as a WHO, the green category, that is the most utilized group of antibiotics that are given. And you can see that this pattern is really consistent across countries and doesn't again change whether the patient is mild or moderate. You know, we still see the same pattern. In terms of what type of antibiotics are given, you know, we see that macrolides and fluoroquinolones and 3rd and 4th generation cephalosporin are the antibiotic mostly utilized in countries. Now, I'm moving now to the second question. What is the prevalence of bacterial co-infection and infection caused by drug-resistant organism in patients hospitalized with COVID-19? And we do see that overall, 50% of patients hospitalized report a clinical or confirmed bacterial co-infection, but and more, of course, among the severe critical patient, 20% versus the mild moderate, only 5%. And we do see that there is a high variability across region, and with higher proportion of bacterial infection diagnosed among patients hospitalized with COVID in the AMR region and the least in the Afro region, likely due to lack of capacity or reduced capacity to do a diagnosis of bacterial infection. What is interesting is that among the 10,000 patients that do not have a suspected bacterial co-infection, no suspected bacterial co-infection as reported by the treating physician, still 74% of those patients receive at least 1 antibiotics, despite no clinical suspicions of co-infection. What we do see also that despite the low range of bacterial co-infection is range from 0.7% to 30% according to the country, you see that there is a mismatch in terms of antibiotic utilized in those countries. So between 65% and 97% of antibiotic use versus suspected co-infection at much lower rate. The most frequently observed co-infection around the upper respiratory infection, lower respiratory infection, urinary tract infection, and we still do see a high frequency of resistance pathogen, mostly gram-negative pathogens. Carbapenem resistance is very common for Pseudomonas acinetobacter, and ESBL producing Enterobacterales were also very common. And now we move to the third kind of question, where does antibiotic therapy influence clinical outcome in patients hospitalized with COVID-19? In other words, patients that do not need antibiotics because they do not have any suspected bacterial co-infection, has the antibiotic an impact on their mortality, length of stay, and disease progression? And we do see indeed that there is not a reduction as expected in terms of mortality among patients receiving antibiotic therapy despite not having a clinical suspicious of bacterial co-infection. We actually do see the opposite. We do see actually a potential increase in the risk of mortality among those patients. We also do see that there is not a reduction in the length of stay among patients receiving antibiotics versus those that do not receiving antibiotics. And actually, we do see again a directionality towards an increased length of stay among patients receiving antibiotics if they don't need it. And lastly, we do see an increase in the risk of progression, of severity progression, disease progression towards the ICU admission in mild patients that did not have a need to receive antibiotics, but did receive antibiotics. So this just to suggest that antibiotics may increase and create a worse outcome, contribute to a worse outcome in patients that do not need those medications. So in conclusion, we see that the widespread use of antibiotics in all patients hospitalized with COVID-19 across all the WHO region, all the age groups and severity. We do see that the very high use of antibiotics, even in a mild, moderate patient, despite WHO strongly recommend against the use. Mostly of the antibiotics are prescribed empirically and started within the first 24 hours. And they are broadly a broad spectrum of antibiotics that are prescribed blindly, irrespective of the clinical suspicions of co-infection. And indeed, 74% of patients with no suspected co-infection do receive antibiotics, which are mostly from the watch category, and this is a concern from WHO. And we'd also see that access or use of culture is still suboptimal. Only a quarter of patients with clinical suspected co-infection had a culture done. The gram-negative bacteria are the bacteria mostly frequently detected. And we do see that empiric use of antibiotics in patients that don't have a clinical suspicion of co-infection might even increase the risk of disease progression and clearly are not associated with clinical benefit for the patient. And therefore, antibiotic therapy should really be restricted in patients with a clinical indication. Of course, this analysis has limitation. Antibiotic indication biases and causality could not be assessed. And there is a variability in terms of geographical representation, with some countries and some group of patients maybe are overrepresented, leading to a potential selection or reporting biases. And with that, I would like to just conclude by acknowledging the team at WHO that has supported and contributed to the analysis. A big thank to the Ministry of Health, to hospitals and research networks contributing data to the clinical platform. They are acknowledged on the WHO webpage. And also a thank to the Clinical Advisory Group for COVID-19 that provides strategic direction to WHO. Thank you very much for your attention.
Thank you very much, Sylvia. That was a very informative analysis of the impact of AB, so it is in the antibiotics, particularly whenever you were looking across the COVID and the AMR dimensions of it. Really, really valuable information coming out from that. And it does sort of spring a question into my mind, because there are so many interested parties within all of this, from the clinical domain, from the scientific domain, etc. And I was just sort of wondering, from the perspective of the World Health Organization, how do you think that the World Health Organization, can contribute to sort of tackling some of these issues in and around AMR and the antibiotics as well? I'm sort of thinking particularly in terms of, do we need to do more on health literacy? Do we need to improve GP training? Do we need to improve our data sharing within all of that? And how can we translate that work from the WHO at an operational level, be it in regional, be it national, or be it internationally?
Thanks, John. I think that's that's very important questions, and indeed more needs to be done at any level. I would say, of the healthcare settings to tackle AMR. In 2015, WHO has coordinated the development of the Global Action Plan on antimicrobial resistance and is conducting annually, regularly surveys to see how countries are doing in terms of developing and implementing a national action plan. And what we have been seeing this year, for example, is that despite of the 161 countries that responded to the survey, 88% have actually developed a national action plan. However, only a minority of countries have costed developing an M&E plan, monitoring evaluation plan, not to mention implemented the national action plan. So oftentimes the national action plan are on paper, but they're not taken seriously or implemented by countries. And for example, there are a number of technical areas that are not require more attention. You mentioned, for example, human resource capacity, awareness, education. We do know that that some countries offer at least some trainings on antimicrobial resistance to human healthcare workers, but few countries formally and systematically include AMR into training curriculum of healthcare workers, including GP, for example. And we didn't see any progress over the last 5 years of countries taking this more seriously on board. We do see, for example, gaps in terms of capacity of the diagnostics, the diagnostic test of infectious disease and susceptibility testing. For example, a recent survey that has been done by the African Society for Laboratory Medicine shows that of 50,000 laboratories assessed in 14 countries, only 1.3% had capacity to diagnose bacterial infections, and only a minority of those has capacity to do susceptibility testing. So clearly there is lots of work that needs to be, and the funding that needs to be dedicated to tackle AMR. From the WHO side, what we support countries to the development, the costing and implementation of a national action plan. We do create political momentum and high-level dialogue with ministries. For example, just last week, we had the 3rd global high-level ministerial conference on antimicrobial resistance, and where countries agree to have targets to reduce, for example, the amount of antimicrobial use in the agri-food system by 50% by 2030, to eliminate the use in animal and food production of antimicrobials that are medically important for the human health, and to ensure that by 2030, at least 60% of the overall antibiotic consumption in humans is from the access group of antibiotics. WHO also work on the awareness and advocacy. You may be aware of the World Antimicrobial Awareness Week, support strengthening on antimicrobial resistance and antimicrobial consumption surveillance. We just released last week a global report, we call it GLASS report, that look at trends over time of antimicrobial resistance in different parts of the globe. We also support countries in strengthening antimicrobial resistance laboratory infrastructure, capacity, and services. We do, as a WHO, we drive research prioritization and development. So, for example, we are developing a global AMR research agenda in the human health sector as well as One Health to prioritize the research question that needs to be addressed over the next few years. We develop a priority pathogen list for bacterial and fungi, so a catalog of pathogens that represent the greatest threat to public health. And so these are just some of the activities that WHO is coordinating with partners.
Very much, Sylvia. Madalena, I'll pass across to you.
Thank you, John. Thank you so much for this overview that is suggesting us we need to take action all together to avoid a vicious cycle and towards the next pandemic. So I'm pleased to introduce Dr. Samira Busetta, Policy Officer from DG GROW, the European Commission, to present DG GROW activity in the field of health innovation procurement. Health innovation procurements are very important to speed up the uptake of these innovative solutions that can be shared for the contrast to antimicrobial resistance. So Dr. Busetta, the floor is yours. Thank you.
Thank you, Magdalena. Good morning, everyone. My name is Samira Busetta. So I work in DG GROW in the unit dealing with public procurement policy. And more precisely, I work in the team dealing with strategic procurement, which is about innovation and sustainable procurement. I will try to share my screen. So as it was just mentioned, innovation procurement and I would say public procurement in general is key, especially I think for the issue of AMR, especially because I mean hospitals are public buyers, have to follow the public procurement rules, and the public procurement rules, the public procurement directive allows public buyers to buy innovative solution and to use the innovation criteria. Our main job in our unit and in our team is really to support public buyers to try to target or to identify innovative solutions available on the market and then to use public procurement rules to buy them. Why? Because we are convinced that innovation is key in this challenge which hospitals are facing, which is the green and digital transition, and also to really help hospitals modernize the services they are providing to the patient. So public procurement is the main challenge channel, to invest in innovative solutions and to invest in the modernization of the health sector. Just to give you some, numbers of the power, the economic power of public procurement, and it's about 14% of GDP in EU, and this is why we are in DG GROW using public procurement as a policy to really push the development of innovative companies in EU and so help public buyers modernize and develop more, let's say, smart public services. So innovation procurement is really at the core of different policies within DG GROW or within the European Commission. And as I said, it is linked to different main challenge, which are the twin transition, so green and digital transition, but also to the sustainable development of public buyers and also of hospitals. We also want to use public procurement as a key lever for the economic growth of startups and SMEs. And so our different activities that I will detail aimed really to bridge the gap between the buyers and the economic operators, and mainly startups and SMEs.
Hello, Samira. So apologies. Yes. Just to highlight that we are seeing when you're sharing some bars, I think it's from the speakers from Zoom.
Okay.
If this can be minimized or...
Is it better now?
Yes, and now in the top of, that's right, there is an horizontal bar that maybe it can be also minimized.
I'll try to do this. I'm not a professional Zoom.
If not, we can try again to share the screen.
Okay, try to take. Sorry for that.
No worries.
Hide. Is it? I'll try to. Is it better now?
Yes. Now we can see just in the middle one bar, and That's right. Now we can see it perfectly.
Okay, perfect. Sorry.
Thank you.
So yeah, as I was saying, the innovation procurement is really about procuring innovative solutions, but also helping public buyers to be more innovative. And now I just can't. I see. Yeah. So to help public buyers really to develop more innovative procurement, we use a program within DigiGrow, which is called COSME program. It's a program dedicated to to help SMEs to grow, EU SMEs, and what we're trying to achieve via this COSME program is to use procurement project from coming from public buyers, which have a need to buy innovative solutions which are newly emerging on the market and developed by SMEs and startups, and really to bring these two worlds closer and to make sure that the procurement projects from the public buyers are really targeting these companies. So we really want to have the development of a more strategic use of public procurement for the development of innovative SMEs. So we have different type of activities that I will detail. We have first, let's say, activities which really are pushing public buyers to implement innovation procurement on the ground. We have two types of project. One type is more PPI, and you see radar, and I know that Sion will give you more detail on this project. But the idea of the PPI is really to support public buyers and to support the purchasing of innovative solution and in more, let's say, on financial terms. So we co-fund the project and also the purchasing of the innovative solution. So the idea is really to de-risk financially the investment in a new solution. And we have a second type of project, which is the development of brokerage activities, because we know that even if public buyers want to buy new solution, they need a support of for, let's say, market consultation, how to also draft the tender document in a way that it's more open to innovative solutions. Sorry. So it's really two types of approach, which are really let's say, on one side, helping buyers, supporting them on the more technical aspect of innovation procurement, and on the other side, support them on more financial terms on the procurement of innovative solutions. So our idea is really to, with these two projects, really to help public buyers really to cooperate together, to share the risk of investing in innovation procurement together, but also by making them collaborating on project. We hope that will increase the impact of public procurement of innovation. And this is why we're really glad to support the radar project, because as it was mentioned during the previous presentation, it's an international issue. And with this radar project, we hope that the solution which will be purchased via this PPI will be then spread, let's say, at least at EU level. So it's really important for us to follow this kind of project and to measure the impact. It will also show that innovation procurement is a very, very powerful tool. The second type of activities that we are also carrying out is to support the development of communities of public buyers. We have two types of activities. One is the Big Buyers for Climate and Environment initiative that we had launched more than 3 years ago now, almost 4 years. So the idea is really to bring together buyers around common challenges, and so together they conduct a series of activities, which could be market consultation, engaging with the dialogue with the industry, with innovative companies, but also sharing information and start to draft together what could be what we call a joint statement of demand, meaning that public buyers together let's say drafts in a very standard way the needs that they have of innovative solutions. And the second project we have, it's this digital public buyers platform that will be online early next year, around February or March. The idea is really to host communities of practice of mainly public buyers, but not only, which will work on different topics. We have, for example, one community on AI. The idea is to have public buyers testing some standard contract clauses on artificial intelligence. We also have another community of practice which will work on on solar panels, for example, the how to purchase sustainable solar panels. So the idea is really to have this platform hosting the work of these communities of practice. These communities of practice will have to deliver some product or tools which will really be available for all public buyers across Europe. Another type of activities that we have, we try to build new knowledge, which means that we really want to tackle some very important problems for public buyers and to give them some very technical knowledge, really to support them in the purchase of innovative solutions. And for example, you may know that the directive on public procurement allows the use of the innovation partnership. So how to to have these two contracts in one contract, the R&D contract and also the procurement contract in just one contract. And we have produce this study on how to evaluate the price of the value of an innovative solution. But we also want to address the startups, let's say, environment, and we are about to publish a leaflet for startups and for public buyers on how these two parties can really work more closely together. It was a very short, let's say, a summary of all the different activities we are conducting. We also have a newsletter which is called Public Procurement Gazette, and where you can follow all the projects and activities we are developing. If you have any question, I remain available for a few minutes. Thank you.
Thank you so much, Samira. I think you provided a really interesting overview of the opportunities that the European Commission is setting up for buyers and for procurers of innovation. So I was wondering, just a very practical question on my side, being also the chair of the Reference Type Collaborative Network, if you would be available to give us more details about the digital public health buyers platform when it would be available in February, and also to share some highlights from the innovation partnership guide from practitioners, because I think these are really, really important content that need to be uptaken by our quadruple helix community.
Yeah, about the innovation partnership leaflet we have produced, which is really to give, let's say, very detailed trip on how to use tips on how to use the innovation partnership. We have built this short guidance using a questionnaire we have sent to the more than 100 innovation partnership we have identified across Europe. And with the help of these feedback from the public buyers, we have built this guidance. This guidance is really made in the 4 or 5 steps public buyers could, let's say, or should follow in order to conduct a successful innovation partnership. Because there are several, let's say, difficult parts for the innovation partnerships. I would say for me, the main 3 are: first, how to engage with the market and to know the state of art of the technologies available on the market. And this is something that you need some skills in your organization really to evaluate the state of art and why and which procedure to use before choosing the innovation partnership. So this step is crucial. The second step is how to prepare the negotiation, because it's about a partnership. So it has to be, it's not like a classical procurement. You have to be in a more win-win contract, let's say. So preparing the negotiation, to be well prepared, you need to use this first step on the market consultation and really to get the insights from all the members of the innovation ecosystems and build your negotiation strategy. And this, let's say, I would say the last step, which for us is really important, is IPR. This part is often neglected by public buyers. So we, and also in our guidance on innovation procurement, we have a very detailed annex on IPR and how public buyers have to really build an IPR strategy. There are no, let's say, there are several options open to public buyers, but as I said, it's a win-win contract, so they have to negotiate also the part of IPR. On our digital platform for public buyers, so as I said, it will host the communities of practice. Those communities of practice are not coming from the European Commission. It's not the European Commission who has decided to create those ones. It came from ideas from public buyers who wanted really to work on this kind of topics. So I've mentioned solar panel, also AI, and we are open also to support the creation of other communities of practice. And for example, in the health sector, we will be really glad to support the creation of a community of practice. We'll have 3 layers on this platform. The first one will be, let's say, a classical website where you can find all public information related to public procurement, mainly coming from the European Commission, but not only. We will try also to link our platform to different national platforms, also to let's say spread the information in a more wide way. The second layer will be a forum. So a space for discussion with open to the members of the platform. So everybody can be a member, you just have to create a profile, then you will have access to the forum. You can upload and have access to different documents, and also to a repository of the different EU projects. So our idea is really to let's make sure that the members of this platform will have access to all type of information and also to EU projects, EU funded project. And so the last layer will be a closed one, a private one, only for the members of the different communities of practice. So the platform will be online, finger crossed, February. end of February. And as soon as it is open, we will disseminate the information mainly via our newsletter, but also on LinkedIn.
Thank you so much for all these stimulating highlights, and we will take the challenge. We will take up the challenge, probably from a broader coalition of networks, I hope. Thank you so much. So I leave the floor to John Farrell for the next speaker. Thank you, Samira.
Thank you very much, Madalena, and thank you also, Samira. We're now going to sort of look towards the perspective from the patient, and we're going to look at patient empowerment on AMR across Europe. And I'm delighted to welcome Jose Arroyo Nieto, who's a policy officer at Health First Europe, which is an AMR patient group. Jose, I pass the floor to you.
Thanks a lot, John. Well, first, I'd like to thank the organizers and the speakers for their very interesting previous presentations. My name is Jose. I work at Health First Europe, and I will briefly introduce what Health First Europe is and our AMR patient group that we chair. I will share my screen. Well, Health First Europe is a non-profit, non-commercial alliance of patients, healthcare professionals, healthcare experts, and academics, and the medical technology industries. We are based in Brussels, and we've been around for the past 17 years. And our main goal is to improve and transform healthcare through innovative solutions. And since this is our what Health First Europe is, and since and some of our members, and since Health First Europe is one of our main concerns is patient safety. 2 years ago in 2020, we formed the AMR patient group, which is a patient group made up of patient organizations from across Europe. We now have 29 members. Here in the slide, you can see who our members are. There are different patient organizations from across Europe. Some are focused on specific disease areas, and some are more general national healthcare federations. But we have the common goal of addressing the antimicrobial resistance crisis. This I probably don't need to repeat it too much, because you probably all know, but AMR is one of the top challenges, health challenges that have been identified by the European Commission. Here are just some data of how it affects patients in Europe, in the EU. These are data that you can find in the ECDC's report from last November, and also in the last Eurobarometer survey. As you can see, 35,000 people die each year due to infections caused by resistant bacteria. The cost is estimated at 1.5 billion euros. But unfortunately, only 1 in 2 Europeans know that antibiotics are not effective against viruses. Only 3 out of 10 know that the unnecessary use of antibiotics can make them ineffective. Around 8% of antibiotics have been taken without a prescription, and a large proportion of Europeans have taken antibiotics without justification. Or more than half did not use a test to find the cause of their illnesses before starting the use of antibiotics. So this is just to say that the situation is concerning, as some of the previous speakers also pointed out. Because there's just a general lack of knowledge about this issue, and general overuse or misuse of antibiotics when in circumstances when they shouldn't be used. This is just a quote from Andrea Mon, the director of the ECDC, who points out the relevance of this issue in Europe. Again, as a result of the overuse of antibiotics, and she calls for an improvement in infection prevention and control practices. So this is why we formed the AMR patient group in 2020, and these are our three main goals, precisely to raise patient awareness about AMR and healthcare associated infections, to help reduce antibiotic misuse. As you saw, the awareness is quite low, so that's one of our main objectives. Then we also wanted to build a consistent patient voice across Europe to advocate for national policies to tackle AMR and healthcare-associated infections. We saw that there was a lack of let's say, patient voice in the debates surrounding AMR. There are a lot of patient organizations, but our group is a way to bring them together and to have a common voice in this debate, and then to broaden the debate on AMR to include infection prevention and control measures. Well, here you can see our main policy recommendations, 8 of them, that we included in our 2021 launch declaration that was co-signed by all the patient groups. Summarizing, I don't want to go one by one. Summarizing, we want to improve what we call for the improvement of education and training of healthcare professionals, particularly on this issue of resistance and then an increase of patient awareness and engagement. As I mentioned before, promoting a behavioral change among patients in their use of antibiotics, in their understanding of how antibiotics work, and promote infection prevention, particularly through a wider and better use of medical technologies that facilitate early detection of infections, particularly at the point of care. And this facilitates also, makes it easier for healthcare professionals to determine whether an infection is bacterial or viral and act accordingly. That allows for a more accurate diagnosis. And while our group is focused in human health, we are obviously aware of the importance of taking a One Health approach to solve this issue, to also work together with the animal health sector and the environmental health sector. So this more or less are our main goals. And in terms of our activities, here you can see an overview of some of them. We've we have participated together in cooperation with our national members, and we have our different members. We also have some European members, some global members. We cooperated in the different campaigns on public health and the World Hygiene Day, as you can see here, on also World Patient Safety Day, and the European Antibiotics Awareness Day, and the World Antibiotics Awareness Week. We have developed different communications materials that can be used at different levels. For example, we have here this infographic on the right that we developed last year. The data is a bit still from last year, but that we translated into different languages: Spanish, Italian, French, that can be used just to highlight the importance of using antibiotics correctly. Then the 2021 declaration that I mentioned before with our main policy goals. Then we've also had some articles in the media from last year. And we've cooperated, we cooperate with the European institutions. Particularly, we've created a group of 20, now there are 20 members of the European Parliament who have agreed to endorse and support a group, especially in making sure that the antimicrobial resistance remains a priority at the EU, and that they advocate for positive change also in the respective countries. And in relation to this, then we have also contributed to some of the European Commission's consultations on antimicrobial resistance. In relation to this, we organized last October a high-level parliamentary roundtable debate with some of our MEP ambassadors, particularly with one MEP Knotic, who agreed to host us and support us. The goal of this event was essentially to share the patient's perspective with the policymakers. We invited some of our members to share their own stories, some of them who have unfortunately suffered from resistant infections, to bring their voice to the policymakers. And we also were lucky to have the representation from the different institutions, including the CDC, the European Commission, the European Parliament, and Sweden's AMR ambassador, Ms. Malin Grape, and also representation from the doctors and the medical technology industry, and they all shared their ideas on how to address the crisis, the activities that it should be undertaken, etc. It was a good opportunity to raise this issue at the European level. Here we just have some images from the event. Finally, I would just want to point out that we will, in the new year, we will continue with our activities to ensure that the voice of European patients is taken into consideration in the EU and at the national level. And again, I'm very pleased to be here, and thanks a lot for this opportunity to share the patient's perspective in this important workshop. Thanks.
Very much. Thank you very much, Jose. And that was very informative, particularly looking now at the patient perspective within it all. And I suppose if we are to, really develop and deliver what's termed as, patient-centric health and care services, important that we actually include the patient within that process, particularly in helping to get their perspective on the needs and the requirements of the patients within this. But to do this, and you picked up on it in your presentation, to do this, we actually need to increase their awareness of AMR and the health on the HAIs as well, and also the impact that the use of antibiotics can actually have on this and indeed on their own conditions. And it's within that sort of perspective, Jose, I would sort of like to sort of put to you, what role do you think that the patient organizations should be adopting, to address the AMR, and how do you think that we can actually help to strengthen the engagement with the patients at local levels?
Yeah, well, thanks for the question, John. So as you said, the main issue is that there's a lack of awareness, and this is what our members have told us, in different contexts, that there's just a majority of patients don't know enough about antimicrobial resistance and the correct use of antibiotics. So an important issue is to communicate these risks at the local level. And also not just the risks, but also what the specific actions the patients themselves can take to address this issue. First, obviously, basic hygiene rules, hand hygiene, infection prevention, etc. The use of masks, and also importantly, some of our members have pointed this out several times. A better adherence to the prescribed therapy, because we know that it's not just a problem of taking antibiotics when you shouldn't, but also not completing the treatment as prescribed by the doctor. This has been pointed out by several of our members. Essentially raising awareness about the issue at the local level with specific actions that the patients can take to address this.
Thank you very much, Jose. Madalena, I pass back to you.
Thank you so much, John. We have listened to Jose and learned that the level of awareness at European level is high about antimicrobial resistance and need to take action. As a demonstration of the sensibility of the European Commission to this purpose, I would like to introduce Professor Marie-Cécile Blois, who will talk to us about the challenges emerging from a joint action that has been dedicated to antimicrobial resistant JMRI. Professor Blois, please, the floor is yours. Thank you.
Thank you very much. Can you see my screen?
Yes, we can.
Okay.
Maybe you just need to switch to projection because it is not yet.
Okay, that's the problem of having two screens. So is it okay now? Or is it okay now? Do you see only
Yes, yes.
Okay. So I will change that. Okay, so thank you very much for the invitation. Okay, thank you very much for the invitation. So I will present the first result of the first joint action and when we are going in the future for next year. So as it has been said by the previous speakers that antimicrobial resistance is really a challenge, and with many attributable death at global scale. And what we observed when we started the first joint action in 2017 is that there is a multiplication of national, European, and international initiatives, but few exchanges between the stakeholders. And to tackle AMR, we absolutely need to stop working in silo. That's why the Commission in 2016, just after the recommendation of the Council, wanted to launch a joint action on antimicrobial resistance and healthcare associated infections. So this joint action was a unique place gathering member states and all stakeholders. So we gather 44 partners from 27 member states and a stakeholder forum of more than 45 stakeholders from, you can see on the slide, from different partners for civil society, health professional, patient association, etc. And so the joint action mission was to bridge the gap between declarations and actions, and through fostering synergies among European member states and proposing concrete steps to strengthen the implementation of efficient and evidence-based One Health policies to tackle AMR and reduce the healthcare associated infections. So obviously we didn't want to reinvent the wheel, but the idea was to join forces, capitalize on what already existed, and especially best practices in Europe, and working at the One Health level. So to make a long story short, we have written 7 policy briefs and recommendations. So you can have a look at all these policy briefs on the AMR website. And more specifically, it's exactly what Jose has just said before, the need for to be really implemented on the ground. And so policy brief about antibiotic stewardship, about reinforce the infection and prevention and control measures, also to reinforce the surveillance, with surveillance also in animals. And so we have launched the ER's VET network for surveillance in diseased animal. And also intensifies the antibiotics access and innovation, and not only to new antibiotics, but also to the old one, because there are some countries which do not have access to the existing antibiotics. And that also raised the problem of the supply chain. So that's why we had a work package dedicated to research and innovation to take care of AMR. And so we worked about, we interviewed the member states about their need and about access. And we also proposed an economic model based on the Swedish economic model to intensify antibiotic access and innovation, but with some modification. And this model is under discussion with others by DG ERA. So obviously, based on these results, we wanted to go further, and the Commission in the last EU4Health program launched direct grants to member state authorities to implement AMR measures in member states. So this is under the DG Santé direction, and it's a budget of 50 million euros with a 80-20% co-funding by the member states, so 20% by the member states. So that means that at the end, the global budget will be 62.5 million euros, and the executive agency is HDA. So the key words from this grant call from the Commission were concrete actions, implementation, pilots, on the ground tools. A second keyword is capacity building through expert networks, sharing best practices, also intersectoral actions, and it has been said by Jose, who pointed out the need to also work at human but also animal level. Also to support national activities, member state and national action plan. The main objectives of this joint action is to help the countries, the member state, with EU money to implement and increase their national action plans, and to the national action plan to tackle antimicrobial resistance. And also another important expectation from the Commission is education and training. So 30 countries are involved in this new joint action with 27 EU member states, plus Norway, Iceland, and Ukraine. We have more than 100 partners now as affiliated entities, and France, so INSERM, is again the coordinator. So I used to coordinate the first one, and I will coordinate the second one. So we are writing the proposal, which must be submitted by mid-February on the Commission portal. So we have planned to, and I hope it will answer to the recommendation that Health First Europe edited, especially on the animal and human health approach, and also stewardship, IPC. So the organization of this second joint action will be divided in 10 work packages. The fourth ones, 1, 2, 3, 4, are mandatory work packages in joint action. So coordination, dissemination of the activities of the joint action, evaluation, internal and external evaluation. So it's important we still have a stakeholder forum, and also sustainability of the action of the joint action. So we have a member state engagement, and it's really I hope it will answer to the recommendation of Health First Europe, because this work package was not exactly in the first one, not in the same way, but the idea is really to coordinate the actions between the member states, and that all member states are aligned about the implementation of the action, obviously taking into account the resources of each country, the epidemiology of each country, and the economic status of each country. But we will have what we call a JAMRI liaison, which it will be one person in each country, if possible at ministry level, to follow the joint actions and to implement them in the national action plan, to make the link between the joint action and the member states. We will have a work package dedicated to antibiotic and diagnostic stewardship, because we cannot do antibiotic stewardship without also doing diagnostic stewardship. A work package dedicated to infection prevention and control, both in human health and in animal care facilities also, because we need infection prevention and control, and not only biosecurity in animal health. We also plan to have a work package dedicated to surveillance, and we want to launch integrated One Health surveillance. I mean, you know, there is already human surveillance of AMR in the human side by ECDC, but we also work with ECDC to allow some member states to implement this surveillance in human. But we will also continue to develop the ER's VET program that we launched in the first joint action for surveillance in diseased animal. And we plan to integrate and develop ER's ENV program network specialized in AMR surveillance in the environment. The 9th work package will be dedicated to access to antibiotics and diagnostic, and we will not work anymore on the economic models because it is now in the scope of DG ERA. And the last work package will be on communication and awareness. And obviously we will need for this 4-year program all the stakeholders, and we used to work with Health First Europe in the first joint action, and we will be very pleased to continue. And so thank you very much, and let's continue the collective efforts to keep antibiotics working. Thank you.
Thank you so much, Professor Ploy. I am really impressed by the number of results, interesting results and achievements of JMRI. And I was wondering whether in your experience in this first joint action, you identified some key enablers that could facilitate the scale up of JMRI results, and you are already embedding into the new proposals, I guess. And if there is any role you can, any synergy you think can be developed by innovative ecosystems that can share innovative good practices such as the RADAR project results that we are working on.
Yes, obviously, this is also something that the Commission asked us to work really in synergy with the different program in Europe, the other European program about antimicrobial resistance. And so it's not so easy because there are many programs, and even the Commission itself in the last EU for Health program and the last documents has other grants on quite the same project. So we have to really work in close collaboration with the Commission. So that's why I'm not sure we know exactly all the actions, but we obviously plan to work in close collaboration with RADAR and with also the future One Health AMR partnership and for example, the animal health and welfare partnerships and all the European initiatives. We absolutely need to work together to avoid overlaps.
Yeah, actually, we should make an effort and transform overlaps into strengths. That's enforcement of the objectives. Just one question from the audience. Dr. Vincent Gregg asked whether there are any place for phage therapy. You see.
So, thank you for this question. Phage therapy will be addressed in the work package 9 about access and innovation. Normally, there is a subtask specific to phage therapy.
Thank you so much. So thank you, Professor Ploy, and we look forward to the new joint action. John, the floor is yours.
Thank you very much, Madalena, and thank you also to Marie-Cécile as well. Up to now, within all the presentations and listening to all the speakers, we've actually started to get the perspective from the World Health Organization on the global challenges of AMR. And we've also heard from other colleagues that were presenting that actually informed us about different actions and different initiatives either being taken forward by the European Commission through DG GROW or taken forward through the joint action on antimicrobial resistance. Importantly, within all of that, we didn't forget about the patient at the center of it all. And we've heard that valuable patient perspective coming through. But one of the common themes that were running through each of the presentations was the importance of the data collection and the data sharing within all of that. So I suppose that sort of brings us to the question, well, what can we do to actually improve AMR detection and on our communication systems? And in this respect, I'm going to sort of pass over to our next speakers, Jon Arrizabalaga and Olman Elizondo, who are from Aquas. They're health innovation managers at Aquas, but they're also key participants and coordinators within the Radar procurement, public procurement for innovation project. And their presentation is going to sort of provide their perspective in terms of what the project can do to improve that AMR detection and communication systems, importantly through the cross-border innovative procurement. Jon and Olman, I'll pass the floor to you. I'm not sure who's going to start and who's going to follow, but the floor is yours.
Thank you very much, Jon, for your introduction. I will share the screen. So hopefully you can see it properly.
Yes.
Could you? Okay, thank you. Thank you very much. So thanks, Jon, and thank you for also to all the speakers that are gathering today in this session. It's a great privilege to share Radar project with representatives from the World Health Organization, European Commission, the AMR, European Patient Group, and of course the EU Jamboree. So thanks for making this possible. So we will introduce Radar PPI, which is a European Commission co-funded initiative that aims to improve the rapid detection and control systems to tackle antimicrobial resistance through the public procurement of innovation. So both myself and Olman Elizondo are project coordinators of Radar project, representing the Agency for Health Quality and Assessment in Catalonia. So the problem has been already highlighted and brought by the previous speakers, and from all the fields where we can tackle antimicrobial resistance, the specific needs that has been highlighted in Radar is the need to respond to the joint action on antimicrobial resistance, as well as the European Action Plan from 2017-2020. So we aim to improve the early detection systems to ensure the quality care process, and to be able to screen drug resistant and virulent, and be able to communicate these results as soon as possible to the targeted healthcare professionals in order to improve the treatment effectiveness. This will consequently increase the system resilience, and as well as reduce both healthcare and governmental costs. So Radar project acts as a follow-up of anti-superbugs PCP project, which is a pre-commercial procurement project that started back in 2016 and ended up by March 2022 in this year. And here, 6 public and private procurement organizations challenge the market to develop novel medical technologies with the aim to rapidly detect the presence of multi-drug resistant organisms in the hospital premises, to improve the appropriateness of antibiotic usage, and reduce the community and social care impact of hospital-acquired infections. So Radar project aims to extend and leverage from the outcomes of anti-superbugs PCP project, but not only that. It wants to leverage as well from the new research and development arising from the pandemic crisis caused by COVID-19, also to adapt these needs to the new procurement organizations that are now participating in Radar and will be described right now, as well as develop new reimbursement models, as Samira Buseta was explaining, in order to ensure the win-win for both suppliers and procurement organizations. So describing the consortium, we have 4 procurement organizations across Europe. We have RESA as a central purchasing body in France. It can act as a procurement organization in the name of the healthcare organizations within France. RESA is acting as a lead procurer in the project, coordinated the procurement procedures that will take place in the project. We have the Basque Health Service in the Basque country in the north of Spain with a population of 2.2 million inhabitants. The Oncology Institute of Catalonia, also representing the overall Catalonia region with a population of 7.5 million inhabitants. And last but not least, the Naples University, Federico II, the Department of Public Health, which will procure with the potential to be scalable at the Campania region with 5.8 million inhabitants. So with all, there is an scalability potential for 80 million inhabitants, which is a relevant fact to showcase. However, they are not alone. There are 5 supporting entities supporting across the preparation and execution of the innovation procurement. AQUAS, the Agency for Health Quality and Assessment, as coordination entity. We have INSERM, with a vast experience in antimicrobial resistance, and as we have observed, coordinating the EU JAMBRAE. The international network of SMEs, who is also opening the gates of some representatives of the industry, not just in Europe, but all over the world. Jura Consulting, with a great experience in innovation procurement. And Biodonostia Health Research Institute, that is supporting the Basque Health Service in the Basque Country along the project. So 13 partners looking to tackle the antimicrobial resistance through innovation procurement. And the model that will be implemented is the one that is presented right now. We are commonly working right now to commonly identify different needs in the 4 procurement organizations. Some of them are common and some of them are more specific according to the local context. So then, now that we have identified our needs and we have transformed them in clinical demands, we are now engaging with the market in order to assess to what extent this is attractive for the market, and if there is need to be refined in some aspects in order to lead to an effective innovation procurement procedure. So we are working on common market consultations and also additionally in local market consultations in the future. This will lead to individual tendering per locality in order to adapt the innovation procurement procedure to each of the healthcare organizations' contexts. And this is aiming to be launched in October 2023. And if everything goes as planned, to have the contract signed by April 2024 and have a 1 year and 9-month contract with the potential suppliers. And if this goes right and with the learnings, to be able to replicate and escalate these findings at a regional and national level. So far, the results that we have taken after this collaborative work in the common needs identification is that there is need to improve the rapid and accurate detection systems. So we need a solution that can identify the specific multi-drug resistant organisms as well as the resistant phenotypes and or genotypes. The solution shall be placed in different areas of the healthcare organization, such as the microbiology lab, point of care, or even the primary care, as well as the ICUs, and be easy to use and minimally invasive and intrusive for patients, while of course maintaining the safety and accuracy of the results. Additionally, it was highlighted during this preparatory phase that there is a need for smart AMR management systems in order to be capable to transfer these detection results to the right people in real time and in a way that can elicit a prompt and informed response. There is need as well to enable the secure storage and clinical access to pertinent information about the patient's AMR status, and all this to be integrated within the organization's clinical and AMR management workflow and interface with the health information systems from the hospitals. So with these results, we have recently published the market sample prospectus, which is a document focused with the target of the industry in order to explore, first for us to inform the market about what are the clinical demands that we have identified, and as well as further proposes is to explore what solutions are or could be available, as Samira was explaining, to better understand current state of the art in the field, to also understand what timeframes over which these solutions can be mobilized or become available, and also to be able to receive some information that could provide the buyers group information on how they can support suppliers and innovators to deliver these innovative solutions that we are looking for. So this report is already available in Radar PPI website, and supply chain representatives are invited to complete a response form, which deadline is February 3rd, 2023. So here we support the suppliers or potential interested suppliers to have a look at the report and to respond to this questionnaire. So with this, the overall market readiness assessment and how does it look, we have started with the market sounding, again, to gather a first feedback from the market. The deadline is the 3rd of February, 2023. And we have already set some common and local events in order to perform the open market consultations. The common open market consultation will take place online, and it will take place on the 1st of March 2023, and afterwards in the following days we will perform the local market consultations, which will be hybrid, face-to-face, and also with the possibility to attend remotely, and it will take place in procurement organizations places. So it will take place on the 2nd of March in Naples, 8th of March in Paris, 9th of March in Barcelona, and the 10th of March in San Sebastian. So any, again, interested suppliers willing to attend to any of the market consultations, you will be more than welcome. Last but not least, we are aiming, depending on the conclusions that we take in these 3 stages, to open the floor to any interested parts of the supply chain to have bilateral meetings with structured interviews in order to gather more information about potential barriers and additional actions that the procurement organizations could perform to support suppliers to deliver an innovative solution. So with this, I hand over to Olman, who will describe different actions that, depending on the kind of a stakeholder that you are, to how can you be involved in Radar project as well. So Olman, the floor is yours.
Thank you, Jan. So as Jan has mentioned, we are ready to also open this participation in this collaborative effort that all the previous speakers have spoken about, this global need that we have. We have different roles from which we want to permeate the value that each one of them can add to this procurement process, from the patients, from the healthcare professionals, the healthcare providers, the hospitals and the primary care centers, the health system as a whole, and the society also in the global element, which was also highlighted. All these different levels in which AMR has an impact. We are addressing it also as this multi-stakeholder problem into which we want your capacity to interact with us. So first thing you could do is a response form of the market sounding perspective. We also have a forum of interest of an AMR, and we also have our projects, the website, LinkedIn, and Twitter. And if we move forward, then we can see in terms of the market prospectus, and this is you can find the link on the chat. Here you can have on the procurement side the place where you can download this market sounding prospectus, which is targeting the supply chain, in which you can read this work that has been done from all the consortium team and experts that we have, and that you have seen the buyers, and we have involved here all the microbiologists, all the experts. And here, then one first thing that the supply chain can do in this case is read it and see how they can participate. Here as well, you can find the market response form in which you can interact by filling in the form and already provide us with your interests and information. And here as well, you can already register for the open market consultation events that are going to take place, whether the global or the local ones, in terms of the markets that you're prepared to participate in. And you can sign up for the one-to-one meetings. If we go to the next slide, then we can, we have provided for all those other stakeholders that are interacting in here, like the patients that we've had, like any interested organization. We have a forum of interest on AMR that is hosted here on LinkedIn as a closed group. We want to ask you to join and share your perspectives and engage with this conversation that we collectively must have. If you go to the web page as well of the forum of interest in our radar page, you will have a more explanation on what we're expecting to do at that forum of interest. And if we go to the next slide, what we can do right now is already try to open this interaction with you. So if you be so kind to go into this WooClap, you could share this by joining. We have the link also on the chat, maybe, and otherwise you can just go to wooclap.com and put the Radar AMR code for you to participate. Now we've seen it here on the chat, so you might just click on it, and then we can be able to engage with you, which is the purpose of this. Let me see. And here, okay, first thing we're going to ask you to do is to give us which sort of stakeholder type would you consider yourself to be, so that we can identify if you're patient advocate, or citizens. We want this to be a citizen awareness element. So we want maybe also to interpret what sort of needs, as Jose mentioned, that we should focus, or if you're a clinician, a healthcare professional working on an organization, a healthcare organization and management, taking the decisions to those action plans that need to be operated, health system, as payer, or the policymaker trying to introduce the vehicles to solve this global challenge. So So here we go. You may just, click and validate. And we're seeing already here, we have some representatives from the healthcare system, some clinicians, some patients have joined us, which we are all very thankful for all of you to have participated in this webinar. So thank you for this, and thank you for collaborating on your answers. And okay, maybe if we are all already set, we can go to the next one. And here we just want to share, what would you consider to be those topics that would be most relevant for us to discuss in this forum to tackle AMR. So here you may also introduce, in terms of words, topics, hot elements that we've already seen during the presentations from all of our speakers. So we were starting to see here show up some results, stewardship and awareness, very important. This has been mentioned all over the place. And new detection technologies, which is actually what we're trying to tackle here on the radar, and also rapid detection, the element of how quick we can act once we have this problem. Then we are seeing here some very interesting information show up. And this is great, because this is also exemplifies the collaborative action that it could be gathered from this collective effort that we're trying to harness together and to open the channels for you to, participate and add the inputs that all of you from the different expertise and perspective must share and are capable to, put the patient in the middle, which looks quite nice.
We're seeing really a lot of topics to discuss in the future, Olman?
This is great. This is great because we want that forum of interest to be actually, an active place to gather and to have this discussion elements. So thank you all for your participation. And last but not least, we then also have all our channels already here, which we are welcome you there. We have our LinkedIn and a Twitter account, and of course our web page. So we're very excited for the effort that we're collaboratively driving forward, and look forward to have you take part in it. So back to John or Madalena.
Thank you very much, Olman, and thank you very much, Jan, as well. Really, really interesting, and you emphasize the importance of getting engagement across the spectrum within this. Love the little exercise that you actually included into it to get some immediate feedback, which hopefully will sort of go towards the next stages in the project and driving it forward. And you'd said it very, very clearly in terms of how you actually are proposing to sort of get other procurement organizations to take advantage of it through this awareness, through this webinar. But outside of the webinar, what other actions are you actually taking to increase the awareness of procurement organizations across Europe on the radar outcomes? Have you been linking in with other networks or?
Yes, absolutely. That's a great question, John. Thank you. Well, in fact, this exercise that we're having today at this webinar has been an effort in which we try to reach out to all these different stakeholders, relevant stakeholders that accepted to participate here. And we've already spoken with all of them, and this and we have this common sense of having to act collaboratively and together to, as Madalena and Maria Cecile mentioned before, avoid this duplicities, but actually make them a strength. I like that from Madalena, and we plan to also communicate and disseminate as much as we can about both the procurement of innovation process, in which we're trying to use this as a vehicle to work from the demand side, demand-driven need that we have, and provide the elements and the communication with the supply chain so that they can provide us some innovative solutions that could actually be adopted in the system. So we'll be sharing all the information, and we will be debating on the forum of interest. And one first stake that we're going to have is what comes next with Rosanna's roundtable, which I think is going to be a very interesting debate as well.
That's a very interesting. Thanks very much, Olman, on a great link to the next session. So you've helped me ease my way into it. And now what we want to do is to turn our attention to actually sort of consider some of the thoughts in and around how do we create those synergies to tackle AMR. And I would like to welcome Rosanna Alessandrello, who's the Value-Based Procurement Director at EQUAS, who's going to moderate the next session. And I leave it to you, Rosanna, to introduce the panelists as well.
Thank you very much. And thank you also for my panelists. I'm sorry that we are running late, so hopefully we can have, in any case, a fruitful roundtable. I'm going to share 1 second my screen. Can you see it, the slide?
Yes, we can see it, Rosanna.
Okay. Is it the bar appearing to you? No, It's not disturbing. Okay, very good. So today I really thank the organization for giving us this opportunity to have this roundtable on this very interesting matter, and also with this interesting panelist. We have Ana Alvarez, that is the project manager of the Catalan Institute of Oncology, and also together with the Catalan Institute of Oncology, she is representing VINCAT, that is a surveillance program of nosocomial infection of Catalonia. And this entity has been also a member of anti-superbugs buyers group of pre-commercial procurement, and is also member of the Radar Public Procurement Information Buyers Group. Then we have Professor Gernot Marx, that he is the director of the Department of Surgical Intensive Care Medicine and Intermediate Care of Uniclinic Rhine-Westphalia Technical University, Aachen. And he was also member of Anti-Superbugs Pre-Commercial Procurement Buyers Group. And then we have also Francesco Tessarolo, that is postdoctoral researcher, Department of Industry and Engineering of University of Trento, and Bruno Kessler Foundation. And he was the technical leader of the pilot of the anti-superbugs pre-commercial procurement at the Provincia Autonoma di Trento. So we are inviting this mix of speakers, one more clinical, Professor Gernot Marx, one maybe with a more exactly system view, that is Ana Alvarez, because she's representing VINCAT, and then one from more technical side, but again supporting public administration when tackling the adoption of this kind of innovation, it is Francesco Tessarolo. And if we look at what it was anti-superbugs, pre-commercial procurement, that already Jon explained that it has been somehow the source, the father of Radar Public Procurement of Innovation. We already looking at specific topics regarding data exchange, data sharing. We were looking at the data. We expected that this technology was going to be integrated, not only with the electronic record, but was creating a local surveillance and infection control system with an interoperability engine and alert system. And if we are looking at Radar, again also taking into account the slide you already saw from Jon, we are yes identifying specific MDROs with the resistance, but all of this is the basis to then create this data we need to transfer detection result, storage and clinical access of pertinent information, integrated with the clinical workflow. So all these elements make part of this data-driven way to tackle antimicrobial resistance. And so I'm stopping sharing. Stop, okay, perfect. I stop sharing the screen, and now I would like to make two questions to my speakers. I will make these two questions together. I'm sorry, but since we are running really out of time, I don't know how much time you still have to stay with us. So I will do all together, but you have clearly all the I don't know, like 7 minutes each, 8 minutes each, to tackle all of them together, and then I will make a short wrap up. And I will start with Gernot, because he will be Professor Gernot Marx. He will give us the clinical point of view. And before making these questions, I would like also to share something. Highlight something that the previous speaker said to us that they think very important. One predictor of antibiotic resistance is ICU setting. And you, Professor Gernot, you come from ICU environment. And also the use of empiric antibiotics is associated with an increased progression in patients in ICU with no suspected or confirmed co-infections. And then also another element that I think is interesting to put on the table, that buyers from Radar belong to countries contributing more to data on antibiotics use. Italy, Spain, and France, just after UK and Switzerland. With this on the table, I make this question. So are we ready to create data-driven synergies to tackle antibiotic resistance? At what level we can do? Are we ready to do it? Do we have current limitations? Professor Marx, what do you think?
Thank you, Rosanna, and thanks for the opportunity to give my thoughts on this very important topic. So first of all, let's say this is really a very urgent matter. It's not only about resistant bugs and multi-resistant bugs. We also are confronted already again and again in our, especially on the ICUs, with pan-resistant bacteria. In other words, we are back to the, in these patients, we are back to the epoch of before we had antibiotics in our armamentarium, and these patients quite often die in front of our eyes, and we can do nothing basically. And this is obviously dramatic for the patient, but also very frustrating for us that we cannot do anything. Hence, it is very important to tackle this issue and to identify the resistance bacteria, that they are not spreading out further, and that we start at least the necessary therapies as soon as possible. In respect, so we are definitely, this is definitely needed, that we have this data-driven approach. That means in turn on ICUs especially, but also for the rest of the hospitals at least, but maybe even for the healthcare system, that we need really here a digitization throughout the healthcare system, ideally also including the ambulatory sector. And even ICUs, at least in Germany, are not fully digitized right now. We have like 45–50% maybe, but more 45% of our ICUs, and this is more than 1,200 in Germany, have what we call patient data management system. So that means digitized documentation and receiving of the information, not via paper but via computers. That means that we have already a lot of data available. So I personally, at least on ICU and in the ICU environment, I do not miss many data. But the important issue is what you pointed out, Rosanna, in your slide also, is this, that we are getting aware of the data, that we are integrating this into our workflow. And especially in ICU, we have 1,000 data points per hour per patient. So it is very easy to overlook the very important information. And to my experience, also from projects, is that when we have something on our screens, even like a small warning, this is usually not doing the job. Basically, it doesn't change the handling. So we need to think about other ways how we get the most important information that needs immediate action of the staff to bring to the awareness. So we just finished in Germany one large project where we basically handed out to our doctors smartphones with an app, and we identified acute respiratory lung distress syndrome, so RDS. You all know this from COVID-19, earlier than clinically. So maybe we have to think about to do more in terms of getting this really into clinical practice and really to get the information in the right amount of time to the staff, to the doctors. Maybe also let me just think once ahead. So one thing is this really on your own unit. The other thing is getting the expertise. For an example, the infectious disease specialists in Germany, we have 300 for Germany. So the rest of them are in GP practices, and there is not one for each hospital basically. So we need to spread out the expertise for more hospitals, and here really digitized telemedical networks, I think, is a very good possibility to share the expertise, to that we not only have the information ready from the radar system, but also the advice what to do, because this is quite often very difficult. And we started here in Germany, we have the Talea project also in terms that we get the information from other units also to our, in the cockpit, to our central hospital, and we are running a 24/7 support, basically, including infectious disease experts. And just me let a few words. We're just finishing now a project, a 2 years project within this COVID course from the Commission. ICU for COVID was the name, and we spread out the telemedical structure and our Talea idea, basically from our own region throughout Europe. So we had now 9 member states where we are establishing now this telemedical network, and really sharing expertise between hospital, between countries. And I think this is the right answer to the challenges we are confronted with, and basically getting out the best, the benefit out of the modern technology and innovation, and really out of the data we have already in our hands or in front of us. So I think it's quite often not a matter of that we do not have enough data, at least within the hospital or especially on ICUs, but that we get the information out and a base for the right decision, and therefore we need more expertise, and that needs to be shared with telemedicine. Thank you.
Thank you very much for your intervention. So Anna, the same question to you, and also what kinds together the strategies that since also Professor Gernot already somehow answered, but it's good because so we can do all together, no? The strategies or the limitation we have at also level now can create already data-driven synergies, and also the strategy your organization is putting in place to be able to create these data-driven synergies.
Thank you, Rosanna, for your question and the introduction. First, the first question is that if we are ready to tackle these synergies together. But before to answering that question, I think I would like to differentiate 2 levels of the data that we can distinguish from a clinical and surveillance perspective. And I think the 2 levels are the patient level and the epidemiological level. Mm-hmm. And at the patient level, I think it's important that we have some information, for some patient information that is easy to access by the clinician and the infection control teams. For instance, when a patient arrives to a healthcare facility, it's very important, I think, that they have access to information about the patient anamnesis at the microbiology level. We need to know if the patient is colonized by a multi-resistant microorganism or has been in the past. He has had previous infections, or how he has been treated. And why is that? It's not random. I think it is important for manage and treat the patient correctly. And I would like to give an example about, for example, the information that we have in a hospital or in a healthcare facility about allergy information of a patient. It is, I think we all understand that it's very important that when it arrives at the healthcare facility, we know this information, because if not, the patient's life is on risk. And I think maintaining some differences, of course, but I think we can make this similar just to give the importance that the microbiology information has. Now, we see the magnitude of the problem of the antimicrobial resistance. So one of the challenges or limitations that we have now, I think, is that we are not able always to see this information very accessible, and we cannot share it sometimes between centers, not between regions, or more difficult, of course, between countries. And I think it is necessary for sure for stopping the spreading of this microorganism and also the hospitals. This becomes even more relevant when we talk about oncohematological patients. That are the patients that we treat here in our hospital. Of course, not treating fast and correctly a patient with this immune system that is more vulnerable, it can mean the loss of the life. So we really need to test rapidly the patient when we suspect of an infection, and we need to know this information that we were talking about. And I think in this area of the information, we cannot have a barrier of in this interchanging information. And that at the other level, or the epidemiological level, I think surveillance is fundamental to have unified record of this microbiological data, but also antibiotic susceptibility and consumption, focused on the most prevalent microorganisms, but also multi-resistant microorganisms. And it is important, I think, that with this information, we can create maps, sensitivity maps of each region. And I think this is very important to know this information, so that the physicians can treat the patient more directly and with the correct antibiotic. And of course, this is information that here in Catalonia has been working, the surveillance program and maps of sensitivity has been very useful, and we can see already some results that some consumption of the election treatments are going well. I think this is the right direction to go. And of course, for our surveillance systems to work, we need to speak, of course, the same language and terms, using the same methodology to make this data comparable. And this is, for example, a language we are all now starting to use is the UCAST guidelines that the European Commission SME has been creating. And I think it was a really good initiative. And now here in Catalonia and in Spain, we are using this methodology. And I think definitely we need to go through this direction. And of course, if we are ready to create synergies, I think we definitely are ready. We're here talking together in this webinar, and we also are in different initiatives, European Project for Innovation, and as ECO is also working in the JAMRI too. So I think we definitely, ECO is going through this direction to tackle the problem together, not being isolated, but responding. We need to be ready to respond to this urgent problem that is AMR. So I think that's it from my side. Thank you.
Thank you very much, Anna. Thank you. And now it's the turn of Francesco Cesarolo, that he will tackle these questions again. How technologically is it possible to drive this shift towards this data-driven synergies, and how this can be done.
Thank you, Rossana, for this kind introduction, and also it is for me a pleasure to be here at this online event, because I tackle a very relevant topic, that is antimicrobial resistance. So to try to answer to your question, Rosanna, I want to provide another perspective that I think could help understanding how the role of technologies, and especially innovative, groundbreaking technologies, can have in this fight against AMR. So what are the strategies? So for sure, technologies and innovative, groundbreaking technologies are part of this tool we have to implement. But it is not trivial, and it is not simple to really address their efficacy, their safety, and their real contribution to this challenge. We need basically data that is, in this case, data from literature. It is evidence. So just to take these technologies based on evidence and supported by evidence. I think that on this, it is important to take into consideration a recent regulation that has been set by the European Union, the regulation on HTA for innovative technologies. It is a very recent regulation, the regulation 2282. It has been released on 15th of December of the last year until 2021, and it is expected to be in force by January 2025. So we are actually working, all the technologies associations, as Technology Assessment Association of Europe are working toward creating this network and toward creating documents and supporting the creation of evidence on innovative technologies. I think that this is a tool that we have to work with, and we have to take the best that can be produced by this regulation. Of course, the output of the technology assessment of innovations on innovative technologies is definitely to better identify the true value, but the true value of the technology means not only the pricing, but the pricing is of course needed for reimbursement indications, but actually the real added value that the technologies that are really innovative, so that they are game changer, can really add. So this is definitely more difficult to identify, and because basically the very innovative technologies, as the one that we saw in the anti-superbug projects probably, and also the one that are most probably taken into consideration or will be taken into consideration in the radar projects, are complex, are a little bit different from the conventional health technologies we are used to deal with. And this in particular for the fact that there are several users for samples, there are different interfaces, there are different kind of approaches, there are hardware parts, there are informatic parts, IT parts, and so there is the assessment of such a complex technology is definitely more complex than the usual one. We have to take into consideration perspective of different users like patients, but also of course professionals, but also in the professional range, probably a larger range of professionals. We have to, for example, take care of caregivers, both formal and maybe also informal caregivers that could be part of the use of the interaction with these technologies. The other point that we have, the other tools that we have for addressing technologies and technologies effectiveness and safety are standards and norms. Unfortunately, I have to say that this currently presents several big limitations. So especially for innovative or very groundbreaking, really groundbreaking technologies, standards and norms are typically not available or are not fitting properly with assessment of the performance or safety of innovative technologies. And that's why we need also to be innovative in norms, so create new norms, update standards. So push for really standards innovation. And the best way for pushing for standard innovation is try to push for standards that are evidence-based, and moving from what is now the nowadays process, the typical nowadays process of standards that is consensus-based, to more evidence-based standards. Taking into consideration these two big points, we understand that what is really needed is the evidence. So it is real evidence, unbiased evidence, scientific evidence, made available, open, accessible, and performed in the correct way. And this is the other big point and big limitation that we currently have, and we currently have experienced also in the PCP anti-superbug project. So we need for medical technologies the clinical testing, basically the field testing at least, and this is tremendously time-consuming, and unfortunately the time-consuming process for testing efficiency in the field is not compatible with innovation, with rapid, effective innovation that really enter effectively into the field. So that's why we need to study, to discover and to test and prove new effective ways of field testing for guaranteeing at the same time safety during testing, but at the same time timely results. So just to go a little bit quick to the end of these comments, what we saw in the anti-superbug is that we need to involve or speed up the process of testing innovative technologies in the clinical field. We need the involvement, the proactive involvement of the ethical committees for samples or the competent authorities. They have to be aware of the need of being really timely effective in addressing these new technologies. We need to, in a way, tackle differences among EU countries that are still present in the regulatory framework. So we are now hopefully moving from MDD, so Medical Device Directive, to a Medical Device Regulation. This will for sure help on this. There are steps to be performed towards classification, clearer classification of these kind of technologies that are often quite difficult to cluster into the current way of classifying medical devices, for example, or software, because they are borderline usually between the two. And there is also the need to change a little bit or integrate our outcome indicators. So just moving or integrating what is efficacy also with maybe usability, acceptability, satisfaction, intrusiveness, patient discomfort, or something like that, that are also big values in the use of these technologies, in the introduction of these technologies. And that's it. What at the local level, so in the Trentino province, we did, following our experience with PCPs, is for sure to catch some opportunities. And what are the lessons learned that we try to integrate in our activities? It is for sure the opportunity and the usefulness of keep a continuous collaborative interaction between procurers and suppliers. So not just a two bipolar approach, but a really synergistic approach in creating, identifying needs and proposing a constructive demand and offer approach. The other is really the possibility that is possible actually, and we saw that it was possible during the PCP to iterate this process of designing technologies for health according to the every time updated and renewed needs and priorities identified by the procurers. So that's a sort of iterative process. And then for sure, and we see also locally, and now we are more facilitated on this, explore new clinical investigation design. So clinical investigation is something that is key for testing the efficacy and the safety of the medical technologies. But as I previously said, there is the need for having new designs that are more time effective. And in the end, we all saw that stimulate team working among different pilot sites, but among different countries is key. So it is still key as we are. That's why we are also at this webinar online. So that's my contribution. Thank you.
Thank you. Thanks to all the speakers, all the panelists. Thank you very much for coming, for joining up to this time today. So just a very short keywords, that you said during during your contribution. Very few elements, because really really late. So we need to make sure that we have the data, and we digitalize also as well, because again, the digitalization aspects are not at the same level in all the institutions, in all the countries, across the same countries. When we have the data, we need to make sure that the data, relevant data, are coming meaningful to the in a meaningful attention to the healthcare providers, to the healthcare professionals, so that they can take a decision and they are not overlooked. Also, again, together with the data, why not? This is very key. Key factor also sharing expertise. With sharing data, sharing expertise, sharing knowledge. So the data generate knowledge, but also the expertise support to generate the knowledge that maybe we don't have in other settings, or in the same setting but in other healthcare providers. So this network creation, not only in the same setting, but also cross-border and
Rosanna, you're mute now.
Sorry.
No problem.
Okay. So this collaboration across country, but across setting and cross institutions. Also creating and adding to the patient histories elements that we can then capture when these patients go from institution to institution, from different, again, healthcare levels and setting, like, for instance, the patient infection history, and the patient infection, how there's been treated in the previously, and also if there has been already an infection, resistant infection for this patient previously, and how this is relevant for specific patients, not only in ICU, but also with oncohematology patients. And also how this is key, because at the end of the day, it looks like that if we don't we don't make any concrete actions, unfortunately, maybe it looks like we go back to the history when we didn't have antibiotics available. And from surveillance perspective, having these sensitivity maps, and to create so the way to integrate data in a way that these maps of sensitivity across the territory, across the healthcare systems, support then at the end to create this the information regarding the susceptibility to antibiotic, and to treat patients with the current antibiotic since the beginning, since the starting. And then at the end, very relevant when we are talking about innovation procurement, preparation procurement, when we are talking about the one day we want to deploy and adopt this innovation fruit from this procurement, I will start from your last point, to really, Francesco, to really design new clinical investigation process and protocols, to make sure that through this clinical investigation, we already from the very beginning design the innovations in a way that little by little they create the evidence we need. We need also to comply one day with the HTA, the new HTA regulations that still is not in force. We also create the evidence for determining the value that we bring to the different stakeholders, to the different users of these technologies, and also take into consideration that the technological approach are of service of creating values of this to the different users, and then that the value is not we should not take into account just the price for reimbursement. We should not just take into account, clearly they're important, no? The safety, the efficacy, but also other elements like usability, user acceptance. So the values that are really relevant also from the user perspective and from the buyer's perspective. So with all of this, I think that I try to make a wrap up. Hopefully you are satisfied, and but I am, because I really think that we got very relevant keywords and messages with this table. Thank you very much for your participation. John or Maddalena? Yes.
Thank you so much, Rossana. So you summarized really nicely many of what has been reiterated throughout the different presentations. I think that really we need to bring together our forces to avoid the next big health crisis, like Jose Arrojo Nieto referred this morning. And we need to listen to the patient's voice, to engage them in our efforts. And ill health has no boundaries. This is something that has been highlighted by WHO. We need to be aware that AMR struggle is fought not only in Europe but worldwide. So we have to stimulate countries and regions to join the invitation of WHO to contribute their data into the global repository. John.
Yeah, maybe just if I can add that, Maddalena, as well on it. You know, we also heard about the digital public buyers platform and what it will actually do to enable that sort of better collaboration and bringing together the different experts so they can actually set out, you know, the needs, the requirements, also consider things like intellectual property within all of that there. And I think in terms of that digital platform, buyers platform, you know, we'll probably look to organize something early next year and maybe be able to provide some more information on that as well. But the other key message I was hearing coming through from one of the presenters was in terms of this innovation partnership and the guidance that is already available out there for everyone. And that is the guidance for the, you know, the public provider in terms of how they can better engage with the market, know what is available within the market that they can actually tap into. Importantly as well, you know, how can they, you know, better prepare themselves for the negotiations with the different SMEs and companies when it comes to looking at that whole procurement dynamic. And the third element within all of that, which I actually thought was important as well, was the whole thing about having a strategy for IPR within the public provider. You know, we've heard in presentations today, but other times on the importance of IPR and being able to understand what it is and to be able to protect it as well. And I think that is important. And when we sort of look again at the sort of collaboration, which was a key message coming across, we need to start to build that synergy between, you know, the buyer and the provider. We need to empower the SMEs in a lot of respects so that they can actually look into and maybe take advantage of opportunities that may be provided by the Commission, you know, through COSME, through its competitive enterprises and SMEs funding programs as well within all of that. And I think maybe sort of, Madeline, I'll pass back to you for a final conclusion, but I really do think Radar, you know, is demonstrating, you know, through the presentation from Allman and from Jan, you know, that it is a practical way to actually look at innovative procurement and how it can actually facilitate the identification, the adaptation and the adoption and the scale up of the different tools to address, that will contribute to addressing AMR within the EU context.
Yes, thank you, John. I would like just last to refer to the hidden battleground that is in the ICUs now, because this is where the last battle against antimicrobial resistance is being fought by clinicians, and we need to strengthen the engagement of all other parts of the ecosystem around antimicrobial resistance contrast to support the collection and sharing of evidences and data-driven decision approach to change the workflow, like Professor Mark said. This is extremely important. So we are all together in this, and as RSCN coordinator and together with John, the director, we can ensure the support from the RSCN to all what has been discussed today. So I would like to wish everybody Merry Christmas, Happy New Year, and thank you for connecting, although it is the 21st of December. Thank you. A special thanks to all the speakers.